Hello, dear student. Our lecture today is the disorder of the urinary bladder. Like any other organ, the disorder of urinary bladder is either congenital or acquired. We'll start off the congenital anomalies of the urinary bladder. First of all is ectopia vesicae, or what's called exstrophy of the urinary bladder. Is a complete ventral defect of the urogenital sinus and the overlying skeletal system. Other congenital anomalies are frequently associated with exstrophy of the urinary bladder. The lower central abdomen is occupied by the inner surface of the posterior wall of the urinary bladder, its mucosal edge fused with the skin, and the urine spurts into the abdominal wall from the ureteric orifices. The rami of the pubic bone are widely separated. The pelvic ring thus lacks its rigidity, and the femur is both of femurs are externally rotated. That's why the child waddles like a dog. Since the rectal muscle inserted on the rami, they are widely separated from each other inferiorly. A hernia made up of exstrophic bladder and surrounding skin is therefore present. Episodus almost always accompany these congenital anomalies. Many untreated exstrophic bladder reveal fibrosis, derangement of the muscularis mucosae, and the chronic infection. These changes tend to defeat effort to form bladder of proper capacity during reconstruction. Adenocarcinoma are the most common type of carcinoma developing in the exstrophic bladder, which is differ from the usually common adenocarcinoma of the urinary bladder, which is the transitional cell carcinoma. Renal infection is common, and hydronephrosis caused by uretrovesical junction obstruction, which may be found on the urography. These films also reveal separation of the pubic bone. Treatment usually accomplished by surgical repair as early as the first week of life. This picture showing a child with bladder exstrophy. You look the lower abdomen in the center is occupied by the bladder, the posterior surface of the urinary bladder, and the two ureteric orifices from which the urine is exuded into the outside, and this form a hernia. So it should be corrected in the first week of life when the pelvic ring is still malleable and can be reconstructed. But later on, the surgery will be complicated because the bladder have small capacity when there is chronic infection and fibrosis, and also the pelvic ring need osteotomy later on. While in the first week, probably it can be the pubic bone coming to each other by just suturing with nylon or strong stitch that can be approximated. This picture showing the pubic diastasis, the pubic bone are away from each other. And this picture is after surgery, after reconstruction of the urinary bladder. And you see there are double J in the ureter, both ureters, right and left. And there's also a drain from the urinary bladder. The other congenital anomaly is persistent urachus. You know from embryology that the allantois connect the urogenital sinus to the umbilicus. Normally, the allantois is obliterated and is represented by fibrous band called urachus. The urachus extends from the dome of the urinary bladder to the umbilicus or the navel. Urachal formation is directly related to the bladder descent, and lack of descent is more commonly associated with patent urachus than with bladder outlet obstruction. Incomplete obliteration sometimes occur. If obliteration is complete except the superior end remain open, then draining sinus of the umbilicus will be formed. If it's become infected, the drainage will be purulent. However, if the inferior end remain open, meaning the end attached to the urinary bladder, it will communicate with the urinary bladder, but this don't usually produce symptom, and it causes what's called bladder divertically. Rarely the entire tract remain patent, in which case urine drain constantly from the umbilicus. This is up to become obvious within few days of birth. When the child is urinate, the urine exudes from the umbilicus. If only the end of urachus, both ends of the urachus seal off, a cyst at the body of the urachus may form and may become quite large, presenting lower abdominal mass. If the cyst become infected, sign of general and local abscess will be developed. This picture showing three types of urachus. The first one on the left, it's communicate with the urinary bladder and form divertically, and in the middle, both ends are sealed and forming cyst in the abdominal wall. And the last one, the whole urachus, the two ends of urachus is open, and this usually presented early in life when the urine exudes from the umbilicus. Adenocarcinoma may occur in the urachal cyst, particularly at its vesical extremity, and tend to invade the tissue beneath the anterior abdominal wall. It may be seen cystoscopically. Stone may be seen in the cyst of the urachus. These can be identified by plain X-ray film. Treatment consists of excision of urachus, which lies on the peritoneal surface with a bladder cuff. If adenocarcinoma is present, radical resection is required. Unless other serious congenital anomalies are present, the prognosis is usually good. The complication of adenocarcinoma offer bad or poor prognosis. These are two types of congenital anomalies we discussed, and now we will come to the acquired disorder of the urinary bladder. One of these acquired disorder is what's called interstitial cystitis or Henner ulcer. It's a primary disease of middle-aged women, but it can rarely affect the men also. It's characterized by fibrosis of the vesical wall with consequent loss of bladder capacity. Frequency, urgency, and pelvic pain with bladder distension are the three principal symptoms of interstitial cystitis. Interstitial cystitis is a syndrome of mystery in urology. Diagnosis by exclusion. Triad diagnostic criteria is the suprapubic pain at full bladder and relieved after voiding with severe frequency and nocturia. And there is a sterile urine usually to differentiate this interstitial cystitis from bacterial cystitis. It had a sterile urine. Characteristic cystoscope finding, as we see later. Pathogenesis infection does not appear to be the cause of fibrosis of bladder wall because the urine is usually normal. The cause is still unknown, but the primary changes is fibrosis in the deeper layer of the bladder wall. The capacity of the organ is decreased and sometimes markedly. The mucosa is thinning, especially where the mobility is greatest, as the bladder is filled and empties, i.e. it's over the dome. When there is movement of the urinary bladder, so there will be thinning of the mucosa, and small ulceration or crack in the mucosa. The mucous membrane may be seen very thin in this area, and also ulceration sometime, what's called Honor ulcer. In most severe cases, the normal mechanism of the uretrovesical junction is destroyed, leading to vesico-urethral reflux. Hydronephrosis and pyelonephritis may ensue. Clinical finding. Interstitial cystitis should be considered when middle-aged women with clear urine complain of severe frequency nocturia and suprapubic pain on vesical distension. There is a long history of slowly progressive frequency and nocturia, both of which may be severe, and this differentiated from bacterial cystitis. It is gradually progressing, while an infection is usually of sudden onset. The history does not suggest infection. Burning on urination or cloudy urine, these are features of urinary tract infection or cystitis. Suprapubic pain is usually marked when the bladder is full. Pain may also be experienced in the urethra or perineum. Is relieved on voiding. This is important. Gross hematuria occasionally noted, usually when urination postponed, i.e. following vesical overdistension. The patient is tense and anxious. Whether it's primary or secondary to the prolonged symptom, it's not clear. A history of allergy may be obtained. Physical examination usually normal. Some tenderness in the suprapubic area may be noted. Laboratory finding, the urine is almost always free of infection. Microscopic hematuria may be noted. Renal function tests are normal and less complicated by reflux or obstruction. Excretory urograph is usually normal unless reflux has occurred, in which case hydronephrosis is found. Accompanying cystogram reveal bladder of small capacity. Reflux into dilated upper tract may be noted on cystography. Instrumental examination, cystoscopy is usually diagnostic. The vesical capacity is low as 60 ml. The bladder lining may look fairly normal. However, if a second distension is done, punctate hemorrhagic areas may appear over the most distensible portion of the bladder wall, which is usually the dome. With further distension, congestion, edematous reaction, petechial hemorrhage, glomerulation are common finding. Differential diagnosis of interstitial cystitis are cystitis of chronic infection like TB and schistosomiasis and non-specific vesical infection. Treatment, there is no definitive treatment for interstitial cystitis. The therapy employed afford partial relief, but it may be completely ineffective. General or vesical sedative may be prescribed, but seldom offered relief. Hydraulic overdistension or instillation of 50 ml or 50% dimethyl sulfoxide into the bladder every 2 weeks for 15 minutes. Cortisone acetate 100 mg or prednisolone 10 to 20 mg per day in divided doses for 21 days, followed by decreasing amount for additional 21 days has also been found to be effective. The steroid is usually should be withdrawn slowly. There's no sudden withdrawal of the steroid because it had sometimes dramatic effect on the endocrine gland. Antihistamine may also afford some relief. Heparin, sodium, long-acting 20,000 international unit intravenously daily, also block the action of histamine. And nowadays, heparin can be used intravesical installation via the catheter and clamp the catheter to come in contact with the mucosa of the urinary bladder. Surgical management in form of ileocystoplasty may be done to augment the vesical capacity in difficult cases and not responding to treatment. The second acquired abnormality of the urinary bladder is vesical fistulae. Vesical fistulae are common. The bladder may communicate to the skin, intestine, or female or reproductive organ. The primary disease is usually not urologic. The causes is as follows. The primary intestinal disease, 50% due to diverticulitis, 20 to 25% is carcinoma of the colon, and in 10% due to Crohn's disease. Primary gynecologic disease, pressure necrosis following difficult labor, advanced cancer of the cervix, treatment for gynecologic disease following hysterectomy, low cesarean section, or radiotherapy for tumor, and trauma including iatrogenic trauma. Clinical finding. Vesico-intestinal fistulae symptoms include vesical irritability, the passage of feces and gas through the urethra, and usually change in bowel habit like constipation, abdominal distension, diarrhea, caused by the primary intestinal disease. Sign of bowel obstruction may be elicited. Abdominal tenderness may be found if the cause is inflammatory. The urine is always infected. Barium enema, upper gastrointestinal series, or sigmoidoscopic examination may demonstrate the communication. Following barium enema, centrifuged urine on the X-ray cassette and exposure made the presence of radio-opaque barium established the diagnosis of vesico-colonic fistulae. The radio-opaque barium in the urine, it means there is communication. If you give it swallowed by the by enema or swallowed by the mouth, and you are doing a delineate of the intestinal tract by contrast material. If this contrast material excreted in the urine, it means there is communication. How we discover? We take the urine, do centrifuge, and put an X-ray cassette to see the radio-opaque material. Cystogram may reveal gas in the bladder or reflux of radio-opaque material into the bowel. Cystoscopic examination, most useful diagnostic procedure, shows severe localized inflammatory reaction from which bowel content may exude. Catheterization of the fistulous tract may be feasible. The installation of radio-opaque fluid often establish the diagnosis. Vesico-vaginal fistulae is the most common fistulae we are encountered. It's a relatively common fistulae in secondary to obstetric, surgical, or radiation therapy, or the invasive cancer of the cervix. The constant leakage of urine is the most distressing symptom to the patient. Pelvic examination usually reveal a fistulous opening, which also can be visualized with the cystoscope. It may be possible to pass ureteric catheter through the fistula into the vagina. Vaginography, often successful, show ureterovaginal, vesicovaginal, or rectovaginal fistulae. A 30 ml Foley catheter is inserted into the vagina and the balloon is distended. Radio-opaque solution is installed and appropriate X-ray are taken. Biopsy of the edge of the fistula may show carcinoma. These are types of fistulae. The first one on the left, upper left, there is carcinoma of the colon, which open into the urinary bladder, and there is vesico-colic fistula. On the right one, this one shows there is obstructed labor, and due to pressure necrosis on the vagina, upper vagina, there is an opening between the urinary bladder and vagina. It's called vesico-vaginal fistula. The lower one, there's radio-opaque cystogram, which show the contrast ascend up into the intestine. Differential diagnosis is necessary to differentiate ureterovaginal from vesico-vaginal fistula. Fenzobiridine or biridium is given by mouth to color the urine orange. 1 hour later, 3 cotton bladders are inserted into the vagina, and methylene blue solution is installed into the urinary bladder. The patient should then walk around, after which the bladders are examined. If the proximal cotton ball is wet or stained orange, the fistula is ureterovaginal fistula. If the deep in the middle one, cotton ball or cotton bladder, contain bluish fluid, the diagnosis is vesicovaginal fistula. If the distal bladder is blue, the patient probably had urinary incontinence. Treatment vesicovaginal fistula: if the lesion in the rectosigmoid, the treatment consists of 3 stages. When the inflammatory reaction has subsided, first do a proximal colostomy and wait for the inflammatory reaction to subside. Then the involved bowel may be resected with the closure of the opening of the urinary bladder. The third stage, colostomy, can be closed later. But in small bowel or appendiceal vesical fistula required bowel or appendiceal resection and the closure of the vesical defect at the same time. Vesicovaginal fistula, tiny fistulous opening, may become sealed following the introduction of an electrode into the fistula. We know that the causes of persistent fistula are many. One of the is the epithelialization of the fistula. If the fistulous tract covered by epithelium, then it's unlikely to be closed. If we do de-epithelialization, we just burn the fistula if it is small, and we ensure about the drainage of the urinary bladder, this fistula may heal and sealed. The fistula is sealed. As the electrode is withdrawn, the fistula is coagulated with electrosurgical unit to destroy the epithelium of the tract, and indwelling catheter placed for 2 weeks or more. Large fistula, secondary to obstetric or surgical injury, respond readily to surgical repair, which may be done through the vagina or through transabdominal, transvesical, after 3 to 6 months. We have to wait 3 to 6 months to resect the fibrosis when the normal area is well identified from the fibrous area. So we can resect the fibrous area and we close the vagina in transverse incision and the bladder in longitudinal closure, and we put patch of omentum between them. Fistulas develop secondary to radiation therapy or direct extension by cancer are difficult to close. The other disorder of the urinary bladder is non-infectious hemorrhagic cystitis. Some patients following radiotherapy for carcinoma of the cervix or carcinoma of the urinary bladder are prone to intermittent, often serious vesical hemorrhage. The same is true for those patients taking cyclophosphamide. In case of later, drug must be stopped. To control bleeding, cystoscopic fulguration can be tried, though it is usually failed. If it's failed, then the second installation of 3.9 formalin, preparing by diluting the standard 39% solution 10 times, i.e. 50 ml in 500 normal saline, is more efficacious. The catheter is clamped for 30 minutes, and you have to provide that the patient have no vesico-urethral reflux before this procedure. The bladder lavage with 10% alcohol after the installation of formalin, because long time contact of the formalin with the mucosa, it may lead to burn of the mucosa. Second or third installation may be necessary on subsequent days. Other methods like inflation of balloon inside the urinary bladder for 6 hours, embolization of internal iliac artery in resistant cases, and continuous irrigation with solution, which is ammonium or potassium salt, through 3 ways Foley's catheter may be tried. To reduce the incidence of cyclophosphamide, this is a prophylaxis for cyclophosphamide-induced hemorrhagic cystitis, by giving diuresis and tell the patient to void every now and then, or frequent voiding, to decrease the contact of the drug with the bladder mucosa, in attempt to reduce the concentration of cyclophosphamide metabolite and the duration of their contact with the bladder mucosa. Despite these measures, the mortality rate is significant. Thank you, my dear.